Hello, thank you for joining us for another episode of Wish Talks, where we interview our collaborators and hear about their experiences in research. My name is Brian Crouch, and I'm a research scientist in the Department of Biomedical Engineering at Duke, and also serve as the Assistant Director of Research for the Center for Global Women's Health Technologies. Today, we are honored to be joined by Mercy Asiedu. She's an alumni of the center and one of our current collaborators. Mercy is currently a postdoc at MIT in the Computer Science and Artificial Intelligence Lab. So I just wanted to say welcome, Mercy, and thank you for joining us.
Thank you.
So today we are going to be talking about technology. To start us off, Mercy, could you tell us about your experience in developing technology?
You mean like experience from undergrad, experience in GWHT, or just in general?
In general, go through it all.
Okay. So I think my interest in developing technology for health really started in undergrad, where I was introduced to, I majored in biomedical engineering and was introduced to all like the possibilities technology could play in improving healthcare. And having come from Ghana, where a health system, could use some other technological improvements, BME just seemed like the perfect way to do it, or biomedical engineering. So, there were lots of like class projects in undergrad on different technologies for class-related health projects, and then senior design. But the first time I really got to work on using technology to impact places in developing countries was once I started working with the Center for Global Women's Health Technologies. And that's really why I wanted to work there in the first place, because I wanted to work on biomedical technologies that democratized care, was useful in developing countries, was useful in resource limited settings. And I started working on a device for cervical cancer screening and testing it and prototyping it, and also working on some algorithms to help classify like images that were taken with the device. So at Duke, I worked a bit on the Pocket Corpuscle project. That was my kind of introduction to the lab. I worked with Christopher Lam, who was a former graduate student, in helping test the Pocket Corpuscle device in clinics, and also got to go to Peru to talk to potential stakeholders about how they would use the device and how to get into the market, and about improvements that could be made based on what their needs were. And in addition, I started working on a speculum-free version of the Pocket Corpuscle that could be used by women themselves, and coming up with the through the human-centered design process, on a way that could best address the problem of self-screening and, removing the fear of pain barrier associated with the current exams because of a speculum. So I thought that was really interesting. And as part of that, I remember Dr. Amanajam talking about being able to really allow community health workers or women to be able to do this. There needs to be some kind of risk assessment that goes into it for automatic classification. And that seemed like an interesting project too, even though I had a bit of background in image processing, but not a lot in machine learning. But it was a really great learning experience to achieve the goal of democratizing cervical cancer screening, and it was something that I was very excited to learn about to reach that goal. Yes, so I guess that last project led me to where I am today, because I realized like some of the limitations with the machine learning tools I was using, and my own limitations and my own gaps in knowledge, and decided that a postdoc in a computer science lab that uses deep learning for healthcare would be a great way to fill in the gaps that I had. and to learn from like people who did this as a career. So that's kind of my, I guess, technology background and my journey through different technologies. Does that answer your question?
Great. Yeah, thanks. That's really fascinating to hear. So most of your technology development has been to serve underserved communities in limited resource settings. Can you talk just a little bit about how you go about identifying the design constraints and sort of differences in the technology development process, additional considerations that you have to take when you're thinking about trying to implement something in Kenya or Peru that maybe you don't necessarily consider so much when you're developing something for a technology that would be implemented maybe here in the US?
Mm-hmm. Yeah, that's a great question. And thinking about that question reminds me of a talk by Dr. Bob Malkin, who is a professor at Duke. And he, to him, like when he gave his talk, he mentioned he gave an example of going to, I can't remember the country, but going to a country and realizing there was all this donated equipment that weren't in use, and a lot of equipment that were just, in garbage or in storage because there was no maintenance and there wasn't like any getting like the spare parts for it, things like that was quite challenging. And he gave an example of being in a surgical room. There was surgery going on and the lights would blow up and there would be flames, and then it was like, what's going on? And then the providers are like, oh, this happens all the time, like it's fine. And he realized that it was the wrong spare parts like that was being put in place because that was what was available in that area. So I think in developing things for different settings, one really has to consider like maintenance, how it will be maintained for use, how it would be operated, but also the availability of parts, replaceable parts. And there's a choice of whether you make it, cost effective enough that it doesn't necessarily need replaceable parts, but can just be, if at the end of life, just be disposed of, or if you make it in a way that the spare parts are readily available or are easy to come by. So that was one major consideration. Another thing was considering like things like constant electricity supply, considering the lack of constant internet access. So kind of bearing in mind that perhaps like in rural communities, or like in community settings where this might be employed, there wouldn't be like, Wi-Fi everywhere, or for internet connection, there wouldn't be, there might not necessarily be like electricity that runs day and night, and things could go on and off, and putting that into the design constraints is really useful. I think another thing that I learned in working with both the Pocket Colposcope and the Colorscope was, in our implementation, we really wanted the devices to be, something that could be taken into a community level and transported easily. So portability was also a very important concern because rather than having to make people come to the hospital and creating devices that could only be kept at the hospital, actually having devices that could be taken out into the community to reach more people who might otherwise not be able to travel miles to get to a tertiary institution. Yeah, so those were constraints. Another, I guess the last thing that we really emphasized was on task shifting. So task shifting to community health workers, because there are more community health workers in certain areas than there are providers per the number of people available. So in task shifting to a community health worker who might not have the years of training that a health doctor would have or a nurse would have, creating devices that could be readily accessible at that level was very important.
So it sounds like, one of the big things you also had to consider was adaptability to fit within the community, and then, acceptance within the community. So what other things did you think about in terms of like community acceptance when you're trying to bring a new technology in?
Yeah. So um, in terms of, I guess I can kind of break this down by device type. So like with the Pocket Colposcope, it was, I guess community acceptance was, taking Peru as an example, and like some of the mobile trucks that we were hoping, this could fit in, as an example, being accepted by the community was something that, could easily be using a mobile truck, was accepted by health workers who worked in the mobile truck and getting their responses and what they wanted from a device. So for instance, they want something that, is easy to use, is small enough to keep in a mobile truck without occupying a large amount of space. And in terms of the color scope and, putting women's health in the hands of women, or even removing the speculum barrier for provider-based screening, I think when we showed the Pocket Colposcope to some of the midwives in Peru, they were immediately like, do you need to use the speculum? Can a woman do this herself? And we're like, oh, well, we have another device we are working on, and what are your thoughts on it? And like, they were very interested, and it kind of helps to overcome some of the feelings of vulnerability that if you took a mobile truck to a market and you're trying to recruit men to come and like, get their cervixes screened in a mobile truck, it kind of helps to overcome some of the barriers that someone might have at the back of their mind that, there's this speculum device that doesn't look very patient friendly, or I'm kind of feeling vulnerable just lying on the bed and opening my legs up to this person who I didn't know till a few minutes ago. So we try to involve the providers, but with the Colorscope in particular, we've also tried to hear the voices of the women or the users who would be potentially using it, and interviewing people on what they thought of different shapes and of the device in the early stages. And then once it got to the later stages, like collecting feedback on the experience, on the pain levels, on the ease of use, I think was very important to help optimize and make sure we're on the right path. Also, I ramble on, so if I'm talking too much.
No, that's great. So yeah, kind of along those same lines, one of the big goals of WISH is empowering women. And so I was wondering if you could just talk a little bit about your personal experience as a woman in this field. What are the barriers you faced? And just, overall, what has your general kind of experience been?
Mm-hmm. Yeah. So yeah, I guess in terms of before coming to the US for college, like I was kind of set on this goal to become a doctor, and engineering to me then was something very masculine. Like in Ghana, in a lot of this were occupied by men, and there might be 2 or 3 girls in a class, and they might have this stereotype of being like, kind of masculine. So I was quite surprised about how accessible, how much more accessible it was than I had thought when I came into, when I started doing biomedical engineering. But I think I was also lucky in that my biomedical engineering class was pretty much half and half, 50% men, 50% women, when I was in University of Rochester. And there weren't any really barriers as a female, at least from my perspective, in that area. At Duke, like having Dr. Ramanujam is a female. We have quite a representative division of males and females in our lab, I think was also very encouraging. So I never really felt that being a female held me back. In several ways. The only instances where I have visitors who might be used to seeing more males in engineering and might not even realize that, I was a grad student in the biomedical engineering department, or might not necessarily, at least I felt some kind of imposter syndrome that they might not trust my capabilities. So that might have been the only times I felt a bit bothered.
Did you ever run into anything, outside of the, spheres of, undergrad or graduate school, but also, moving on and going into your postdoc, or even, just in your own professional development?
Mm-hmm. Yeah, my postdoc story is definitely quite different. I think my lab has maybe 2 girls or 3. The only female postdoc in my lab. I think the guys are, my fellow male postdocs are very wonderful, and really help out quite a bit, especially since I made a switch into computer science, which I don't have a lot of background in. So I think it's been helpful in being able to reach out and having a supportive group of men who in my postdoc lab. But I definitely, I guess, don't look like the traditional computer scientist and deep learning person with I won't describe I won't describe who the stereotypical deep learner, but it's definitely not what I look like. So yeah, it's like I'm proud to be in that area, and I'm proud like that I'm there, but it's also I also get to that.
Do you feel like people are surprised when you tell them that that's what you're working on?
I mean, so it used to be, I don't know if it was where I was sitting in the lab or something, but people would keep on coming up and asking me secretarial questions, like, hey, I want to see Regina, can you let her know I'm here? That's my current postdoc peer. Like, sure, that's the office, you can go and ask her. Like, they would ask me some administrative stuff, which because I was new, I also didn't know about, but I'd point them to where the admin was. And, like, it was a bit of, I could definitely tell people were surprised that I was in the lab, and that I was in the lab and that I was a postdoc, much nonetheless. So it was definitely there, and there's definitely been some trying times. But it's also not my background. Like, coming from biomedical engineering and switching into computer science, it's been like a very steep learning curve. I've definitely learned a lot. But I'm glad for the support, but it's definitely been interesting seeing, seeing that I'm not necessarily like what people would consider a computer scientist at that level, or machine learning engineer.
Yeah, definitely. Shifting gears a little bit, I was wondering if you could talk about your experience just kind of living at that intersection of health and technology and biomedical engineering and computer science, and maybe if you can just reflect a little bit on your recent experience with TEDMed.
Mm-hmm. So in terms of being at the intersection of health and technology, I think it's a very, I don't know, it's a very interesting area. And it's actually, I've been in another fellowship at MIT, which is more of a course to kind of understand the need and solution pair and in healthcare with technological innovations. And I was very surprised when I learned like this. So the group in the class is made of professionals like health providers, social workers, nurses, postdocs, engineers. And like it was very interesting when I learned from a few of the those with health provider careers, that some people actually felt technology in healthcare tends to widen gaps in disparities in healthcare rather than close them, which is true. But I guess I've also seen technology, if used in a certain way, could be used to close gaps in healthcare. So for instance, like in terms of there was a lot of news around machine learning being used to predict whether or not a patient needed emergency care or something. And it was completely off with Black races versus white, like people who were Black versus people who were white, and it was picking up on something that had nothing to do with whether or not they needed emergency care because of the historical data. So the historical data was kind of making the model interpret that, the less you spend on your healthcare, the less you need on emergency procedures, which is not the truth. If there's already inequities and people are not able to spend a lot on health, it was definitely widening the gap. And I think having people who are conscientious of these facts and from a diverse array of backgrounds, working on these technologies and bringing in different thought processes to the table and different limitations that the technology might face is very important to prevent it from actually, making existing gaps worse. So yeah, that's the main point I would have about the intersection of health and technology, that there really needs to be a conscious effort to prevent it from making health gaps, worsening health gaps. And on TEDMed, when was that? In March, or was it March? No, it wasn't March. November, I can't remember. But it was a really great experience to kind of be able to share, where I came from and what led me to doing biomedical engineering, and talking about like the color scope and really putting reproductive health care into the hands of women everywhere globally rather than to a specific subset of people, I think was really interesting, and getting the feedback from people who listened about how it really resonated with them. I thought was really good. I haven't watched the video because I don't like watching videos of myself, but yeah, it was a really great experience, and yeah, it was just really good feedback. Yeah.
That's great. So one final question that I had is, you've kind of built this wealth of experience in technology and healthcare and trying to, solve health disparities. Has that changed, or do you now, with everything that you've learned, when you, for instance, go back to Ghana, do you find yourself like looking around and seeing all sorts of applications or all sorts of things that you could do?
Yeah, I think now I've seen this, like, I've definitely, my box of what's possible has definitely grown larger, and like everywhere I see possibilities everywhere, and like how things can be improved. But I've also realized that it's definitely not easy. it's definitely not easy. It took me over a year just to get approval for the research I did in Ghana. And even afterwards, there were still quite a few challenges. So I think, this experience has really prepared me to understand that and hopefully to progress better in the future. But I think I'm determined to work on projects in these areas, and determination, goes a long way. And I'm passionate about, using healthcare to democratize health. So even though it's not necessarily the easiest path all the time, and there's definitely challenges, it's still something that I'm driven by just because I'm passionate about it, and that, helps a lot. Yeah. I have a lot more respect now for people who are working on technology development and for bridging gaps, and people working in public health and global health. I think I have.
Great. Well, thank you so much, Mercy, for joining us for this episode of Wish Talks. It was really great talking with you and catching up with you, and we look forward to talking again soon.
Thank you, Brian. It was great chatting with you too.